Thank you. Thank you. Good morning. Good morning. I have the pleasure of presenting our Mason lecture today. Dr. Sugerman received his medical degree from Jefferson University School of Medicine in 1966, served as a medical intern and then surgical resident at the Hospital of Pennsylvania, which he completed in 1973. He was a lieutenant colonel in the U.S. Army. After the Army, he spent 2 years in private practice in Allentown, Pennsylvania, and then joined the Medical College of Virginia faculty, where he remained for 28 years, and became the David Hume Professor of Surgery, Chairman of General and Trauma Surgery Division, and Interim Chair of the Department of Surgery. Dr. Sugerman retired from clinical practice in December 2003. He has published over 240 manuscripts in peer-reviewed journals, 20 books, 55 book chapters. He was president of the Western Trauma Association and our own society, American Society for Metabolic and Bariatric Surgery. He received a Lifetime Achievement Award in 2010 from ASMBS. He has been the editor-in-chief of Surgery for Obesity and Related Diseases, and now shares this role with Raul Rosenthal. He and his wife, Betsy, we're happy to have in our audience, live in Sanibel, Florida. They have 4 children, 9 grandchildren who live in New York City, Los Angeles, Park City, and Atlanta, Georgia. Please help me in giving Dr. Sugerman a warm round of applause. Thank you so much.
Well, thank you, everybody. Thank you. I'm already over time, so I've got to get going. Before I begin my lecture, I would like to thank those in the Society who nominated me for the Arnold P. Gold Award for Humanism in Medicine. I tried to reach Dr. Mason recently, but he has moved to an elderly care facility, and I was unable to reach him. Today, I invite you to join me on a somewhat complicated and circuitous trip with a few big bumps in the road. From the beginning, I was a rather rambunctious and difficult child, always getting into trouble. Perhaps because of my wild preteen years, I was sent to a prep school in the middle of rural Pennsylvania. They had a guard path there where when you did something bad like hanging toilet paper on the trees, you would be forced to walk around a square for hours on a Saturday afternoon when the school's football team would be in action. Much later, after I had been chosen by a national magazine as one of the best surgeons in the country, my dad's secretary called to express her amazement and incredulity because she remembered my wild antics as a kid and these problems it caused for my father. I was admitted to Johns Hopkins, and I decided it was time to shift into high gear and did very well there. I chose to return home to Pittsburgh and start medical school there rather than at Hopkins. And that was a huge mistake because it brought back a lot of very unpleasant memories from my childhood. And something happened that very few of you know. I became severely depressed, took a bunch of pills, and then was on a train with my father and sister and hospitalized at the Pennsylvania Institute in Philadelphia, a place like one flew over the cuckoo's nest. I dropped out of the University of Pittsburgh Medical School. Depression is a very common problem, including many famous people, as you see here and you know, and it has become epidemic recently in the military. After a few months of therapy, I moved to West Philadelphia and was able to get a job as a lab tech for Drs. Tom Nealon and John Gibbon, the developer of the heart-lung machine, in the Department of Surgery at Jefferson. I felt it was important to come out of the closet about this because of the terrible stigma associated with mental illness. I obtained a master's degree in pharmacology there and then was allowed to enroll in medical school with their full knowledge of my history. I did well there, having taken several of the courses, both in Pittsburgh and for my master's degree. This earned me, This earned me a position as a straight medical intern at the hospital, University of Pennsylvania, affectionately known as HUP. But taking care of medical diseases and not being able to do much for the patient at that time drove me crazy. So I decided to switch to general surgery, and fortunately, Dr. Jonathan Rhodes agreed to take me into the program. It was a great residency and life experience. It was when Stan Dudrick, 2 years ahead of me, developed with Dr. Rhodes the technique of total parenteral nutrition, or TPN. Dr. Rhodes had been working on this for about 30 years. Stan's simple solution was to use a catheter in the subclavian vein, which had been used previously to measure CVP, to put this highly concentrated solution into the rapidly flowing venous system. This was a time when we used protein hydrolysates, not purified amino acids, and some of our patients developed terrible reactions like this one with exfoliative dermatitis. We also didn't know about the need for trace minerals like zinc, selenium, copper, and essential fatty acids. So patients developed severe nutritional deficiencies, but we kept them alive when they normally would have died because they couldn't eat. And then we received every surgical disaster around the area with open wounds, fistulas, short gut syndrome, very, very sick patients who needed around-the-clock care. While a resident at HUP, I worked as a fellow in an NIH-funded shock and trauma center. I had patients with terrible adult respiratory distress syndrome, or ARDS, who had become impossible to ventilate. It was at the start of the use of positive end expiratory pressure ventilation, or PEEP, and we started using it. An internationally known internist at HUP, who wrote the Physiology and Medicine section for the New England Journal, told me I was going to kill my patients using that. He cited a 1948 study on World War II pilots with the hope that people would improve their oxygenation at high altitudes. But they found a decreased cardiac output and venous return, not a good thing when flying at high altitude. But I told them that this wasn't happening to our patients. So I floated the first Swan-Ganz catheter at HUP, and we found that raising the level of PEEP from 5 to 10 to 15 centimeters of water had no effect on the cardiac output or peak inspiratory pressure in these patients with stiff lungs, and their oxygenation improved. The problem with the Cornon study was that these pilots had very healthy, compliant lungs, in contrast to our patients with highly resistant stiff lungs. So this is one of the first lessons I taught medical students and residents. Beware of the full professor. You need to question every dogma that you were taught. We had a great clinical research unit publishing articles in the New England Journal, Annals of Internal Medicine, Journal of Trauma, Annals of Surgery, etc. But the NIH refused to continue our funding, and I became very disenchanted with academic medicine. After residency, I was given an opportunity of being an obligatory volunteer in the U.S. Army through the Berry Plan, just as the Vietnam War had ended. Actually, although I thought I was in the Army, I received a letter in April 1970 saying, "Congratulations, Dr. Sugerman, welcome to the Air Force." All that would be left by this time would be a 50-bed hospital in Minot, North Dakota, where I might do an appendectomy every other week. Basil Pruitt had been one of the site visitors for our failed NIH grant at HUP and was the director of the Burn Center at Fort Sam Houston. He appeared to have taken a liking to me during that grant review. So I called him up and said, "Dr. Pruitt, can you get me back into the Army, even if I don't want to be a burn surgeon?" And he did. I was called by the Army one Saturday morning and asked if I would like to go to Germany. This sounded great, but I asked if I could check out with my wife, who was out shopping with her mom. After telling Betsy about going to Germany when she got home, she was a bit upset. So I called the Army back and asked, what else did they have? And they said, for you, Dr. Sugerman, we have a position in Korea. And so we went to Germany. After residency, I had published over 20 papers as a resident and sent my CV to the Army and asked if they could send me to their main tertiary care center in Landstuhl, Germany. But instead, they sent me to their, quote, other tertiary care center in Frankfurt to become an on-the-job trained orthopedic surgeon. And I didn't particularly like orthopedic surgery, so I contacted the medical commander in charge of the U.S. Army in Europe, who fortunately was also a general surgeon, and he transferred me as a general surgeon to the 130th General Hospital in Nuremberg, Germany. What a wonderful experience. It was an old Luftwaffe Krankenhaus with a huge swastika in the entrance hall covered with a carpet, and a secretary named Frau Schiebeck, who would get on the PA system every week and say that, quote, "There will be a meeting of all the doctors at 3 o'clock, and you will be there." That always gave us a good laugh. We drove an old VW bus and our Pontiac shipped over by the Army all over Europe and to ski centers, using Exxon gas coupons at 25 cents a gallon, when the dollar was also very strong. And I was able to work with colleagues who had trained in other programs. We operated together and exchanged techniques and concepts. It was a great experience. Can we roll this faster? It seems like this. This was where I made another one of my big mistakes. We had a number of older GIs married to German women who were alcoholic and developed chronic pancreatitis. I like to do the Pusto procedure to drain a dilated pancreatic duct with an onlay rouleau. So we would take our patients in what we call a cracker box, i.e. an Army ambulance, to the University of Erlangen, 25 miles from Nuremberg, where they had developed ERCP. They would find a dilated duct and then tell me that the patient must have a Whipple. But of course, we did the Pusto, and their pain went away. But my error was not learning the technique of ERCP and being one of the first to bring it back to the United States. Because of my NIH experience with grant rejection, I decided to go into private practice and believed it was all set up in Reading, Pennsylvania. Unfortunately, on Christmas Eve, I was notified that the hospital had become a closed staff and I no longer had a job. Because it would be difficult to find a position while in Germany, we gave the Army another year and were transferred to Fort Bragg, North Carolina. Fort Bragg is the home of the 102nd Airborne and the Green Berets, a strike Army base. One morning, after spending the night in the ER, Betsy had given me a honey-do list of shopping needs for the PX. I was accosted by a private MP who said, "Sir," and I was a lieutenant colonel by this time, "Sir, don't you think you need a haircut?" And I looked at him and said, "Yes, you're probably right." And he said, "Sir, there's a barber shop right over there. Perhaps you should go there right now." And so I went and got my hair cut. It was obvious that the commanding general must have sent him after those docs who were disregarding the dress code. After the Army, I joined a private practice group in Allentown, Pennsylvania, but it wasn't what I expected. They had a different set of ethics than I was taught at HUP. One quote, "Dr. Sugerman, this is a business, and don't you forget it." I resigned and looked for an academic opportunity because of my productivity as a resident at HUP. I thought I'd be a shoo-in for a good slot, but it wasn't easy. After numerous letters of interest and visits, I was finally offered several jobs and chose the Medical College of Virginia, because Laser Greenfield was there, had done research in shock, and was supportive of my laboratory plans. And for me, it proved to be a great choice. Arriving in Richmond was a bit of a culture shock. One of my new senior colleagues greeted me with, "Yankees are like hemorrhoids. When they come down and they go back up, they're tolerable, but when they come down and stay, they're a pain in the ass." This is the city where Arthur Ashe grew up and learned to play tennis, but he wasn't allowed to play tennis at the Country Club of Virginia after he had won Wimbledon. But Richmond has changed a lot for the better since then. After returning to academic surgery, I knew that I needed to develop a productive laboratory. My initial interest was in ARDS from my days at HUP with PEEP. We developed a porcine sepsis model and were able to conduct numerous studies regarding the pathophysiology of ARDS and attempts to modify its progression by blocking activation of inflammatory mediators such as TNF-alpha and various other interleukins. Funding for these projects through the several major grants that were supported again by Dr. Basil Pruitt. We also began to study the effects of an increased intra-abdominal pressure, or IAP, in this porcine model, as we were seeing many patients with an acute abdominal compartment syndrome in our surgical ICU. We found an excellent correlation between the urinary bladder pressure and directly measured IAP in this model, as well as our patients relating IAP to the sagittal abdominal diameter, or waist circumference, as shown in this slide. My income was to be significantly dependent on my clinical practice, and at that time, I was unable to bill for critical care. And all of the general surgical areas seemed to be covered. All that was available to me at that time were indigent patients with gallbladder disease. We had 4 children at that time, and when I looked at the future need for college education, something had to change. As part of a CME program, I went on the road to southwestern Virginia with a urologist. He talked about penile prostheses for impotence, and I talked about Swan-Ganz catheters for the diagnosis and treatment of shock. And after getting back to Richmond, Dr. Texter had several patients referred for penile prostheses, and I didn't get a single patient in shock. Something had to give. The 1950s and 60s was the era of the jejunal-ileal bypass, or JIB, leaving patients with a great weight loss, but with a rheumatoid-like syndrome, arthritis, cirrhosis, oxalate kidney stones, bacterial overgrowth, malnutrition, and numerous other medical problems. MCV had become a center of JIB surgery under David Hume, its former chairman, who had operated on Al Hurt and the famous New Orleans trumpeter, and his twin daughters, for which he was on the cover of Time magazine. David Hume was famous for his transplant innovations when he was in Boston, and would have probably shared the Nobel Prize for transplantation with Joe Murray had he not flown his twin-engine plane into a mountain outside of Los Angeles, where he went to recruit a pediatric surgeon. By the time I had arrived at MCV, because of all these long-term complications after JIB, no faculty member wanted to get near a patient for obesity surgery. And it was at this time I read Larry Carey's article from Ohio State, presented to the American Surgical Association and published in the Annals of Surgery, on how simple it was to just staple the stomach, take out 3 staples, to make a small pouch with a small opening so patients would get early satiety and lose weight without the complications of the JIB. And they called it a horizontal gastroplasty. So I went to Laser and asked him if he would support my doing bariatric surgery, and he said it was okay as long as I studied what we were doing, and that is one of the greatest pieces of advice I ever got. However, the Ohio State horizontal gastroplasty is another example of beware of the fool professor and don't trust everything you read or hear, even in our most prestigious surgical journal and society with the highest impact factor. They presented 115 patients who had the surgery in just over 1 year, but they had only follow-up data in 7 patients with a 33% failure rate. It became apparent that this was really just a placebo operation. At the same time, Ward Griffin and his colleagues had published a randomized control trial, or RCT, which found that the gastric bypass had weight loss equivalent to the JIB, albeit with more early complications, but without the JIB's enormous long-term medical problems. Our hero, Ed Mason, for whom this lecture was named, and the founder of our society, had developed a loop gastric bypass following encouraging studies in dogs. Dr. Mason later became concerned about the problems of bypassing the stomach and duodenum with iron deficiency, anemia, vitamin B12 deficiency, and calcium deficiencies, as well as the risk of an internal hernia. So he subsequently developed the vertical banded gastroplasty, or VBG, which he came to believe should be the only operation for severe obesity. It was at this time that I stepped onto the stage. Having tried the horizontal gastroplasties and aware of the Griffin study, we chose to conduct an RCT comparing the VBG to Roux-en-Y gastric bypass. Patients were told that we had no idea which would provide better weight loss and the fewest complications. The known complications were explained to the patients in detail, and randomization was decided in the operating room when it was determined that either operation could be performed safely. Within a short period of time, as shown on this slide, it became apparent that the gastric bypass provided significantly better weight loss as early as 6 months after the operation. And so we aborted the study as per our intent to treat protocol. Our dietitians, Jan Starkey and Reggie Birkenauer, noted that the bypass patients were avoiding fats and high-density carbohydrates because they induced dumping syndrome symptoms. So in our next study shown here, we assigned all of the sweet eaters to gastric bypass and those who just ate large volumes of food to VBG. And this study found that the weight loss did improve in the VBG group, but it was still significantly less than the gastric bypass patients, whose results, despite having all sweet eaters assigned to them, were equivalent to those in the RCT. This and subsequent studies were confirmed by others, led to the frequent statement that Roux-en-Y gastric bypass was the gold standard bariatric procedure. Oops. I never coined the term gold standard, object to its use. Since then, the sleeve gastrectomy has become the operation of choice, although it resembles the VBG. There appear to be significant hormonal changes not seen with the VBG, and weight loss is almost the same as the gastric bypass. But as you know, there have been failures with this procedure as well: severe reflux disease, pouch dilatation, inadequate weight loss. But the procedure can be converted to a Roux-en-Y gastric bypass for reflux, or to a duodenal switch type procedure for inadequate weight loss. This slide is going to get me in trouble. Betsy and I met in April of the second year of my residency, and we were married 5 months later on September 1st. Without a doubt, this was the best thing to ever happen in my life. My surgical colleagues in the 1980s gave me a lot of flack for operating on patients who had become severely obese just because they ate too much. But along came a number of supportive studies documenting the efficacy of the operation, as well as a report in the New England Journal of Medicine by a psychiatrist, Mickey Stunkard at HUP, a previous Mason lecturer who died several years ago. In this study from Denmark, he found that obesity had a genetic component. They evaluated identical adopted twins brought up in different homes and found that they had a very tight concordance of their weight as compared to fraternal twins also raised in different homes in whom there was a minimal weight relationship. And there have been numerous other confirmatory genetic studies. Of course, there must be other causes of severe obesity. The exciting thing was that these patients' comorbidities were melting away. I felt like a kid in a candy store. There were so many medical problems that we could study. As you know, these comorbidities start at the head and go to the toes and affect every organ in between. And many of us, too many to be named, most of them here, published numerous articles, albeit mostly case series, in academic peer-reviewed journals, validating the efficacy of bariatric surgery. And our field became respectable and grew like wildfire. When the pulmonologists found out that I was doing bariatric surgery, they started referring their obese patients with sleep apnea and obesity hypoventilation syndrome. This study found marked decreases in lung volumes, especially the expiratory reserve volume, or ERV, along with hypoxemia and hypercarbia. The ERV increased significantly, along with normalization of arterial blood gases following surgically induced weight loss. And there was a marked improvement in sleep apnea. Patients with pseudotumor cerebri had very high opening spinal fluid pressures, which returned to normal after weight loss with resolution of their headaches. Venous stasis ulcers resolved. At that time, we were amazed when a type 2 diabetic patient came in for a Roux-en-Y gastric bypass, taking 100 or more units of insulin a day, and then went home 4 or 5 days later on no insulin. And now, with the laparoscopic approach, many go home the next day on no insulin. In 1995, Walter Porres, here in the audience, published this landmark article in the Annals of Surgery entitled, "Who Would Have Thought It? An Operation Proves to be the Most Effective Treatment for Diabetes Mellitus." Dr. Porres is also a great cartoonist, and we published this very true cartoon in Sword. "Doctor, if bariatric surgery is the most effective treatment for my diabetes, why didn't you mention it?" And now, another one of my big mistakes, not following up on a study comparing patients with a gastric bypass to a VBG after an oral glucose tolerance test. The gastric bypass, but not the VBG, patients had a marked decrease in the area under the curve for insulin and a profound decrease in blood glucose levels, and a marked increase in something called enteroglucagon. Turns out enteroglucagon is a precursor to GLP-1, and we failed to pursue this. But others did and are still working on it today, the four-gut hypothesis, the high-gut hypothesis, or the whatever hypothesis. There are now 8,500 references to GLP-1 in PubMed. It was this time that I began to attend a colloquium organized by Ed Mason at the University of Iowa. After attending several of these and hearing surgeons present their latest iteration of an operation for severe obesity with very short-term follow-up, 4 of us at a luncheon meeting in 1983, John Kroll, John Halverson, Pat O'Leary, and myself, felt that there should be an academic meeting to evaluate the surgery with a program committee, peer-reviewed abstracts, and invited speakers. This was proposed to Dr. Mason, who immediately agreed, and he became the first president of the ASBS, which took place in 1984. I was a member of the program committee from 1984 to 1988. It was that year when the nominating committee had recommended that I become the next president. There was a palace revolt, and a nominee from the floor became the president, with the understanding that there would be an individual from private practice alternating with an academic surgery each year for the Society's presidency. Having put so much effort into the development of the Society and its program for the meeting, I felt unappreciated for my efforts, rejected the Society's new path, and chose to withdraw my membership along with John Kroll. I rejoined the Society 10 years later when I felt there was a new more positive leadership, and then I would have the opportunity to contribute to the field of surgery for severe obesity, an area to which I had dedicated a large part of my life. Now back to bariatric surgery. The Swedish Obesity Study, or SOS, published data in the New England Journal documenting significantly higher recovery rates from diabetes, hypertriglyceridemia, low HDL levels, and hyperuricemia. And then, in 2007, publication in the New England Journal, they found a significant decrease in mortality at 15 years, primarily due to a decreased death rate from myocardial infarction and cancer, even though the vast majority of these patients had a banding type of procedure. And in the same issue, the Ted Adams group from the University of Utah, also a former Mason lecturer, noted a 40% decrease in mortality at 7 years in the surgical group compared to matched controls based on driver license data, with a 56% decrease in deaths from MI, 92% from diabetes, and 60% from cancer. Despite overwhelming evidence from numerous case studies and cohort studies, diabetologists were still very resistant to accepting these data and insisted that RCTs were needed for level 1A evidence. The initial plan for all of these studies was to enroll patients with a BMI less than 35, and I had no problem with that, since the risk benefits for this group of individuals was truly unknown, as insurance didn't cover these patients. But they had great difficulty in finding patients with a BMI less than 35. Another surgical colleague and I had serious concerns as to the ethics of assigning patients with a BMI of 35 or more to the control arm in each of these studies, when the investigators had a very good idea as to the outcomes from the case series and matched controls and a previous RTC. This violated the concept of equipoise. 7 RCTs shown here have been completed, with follow-up in 2 studies at 3 and 5 years. This is a list of the authors and dates of publication. All but the Dixon study began enrolling patients after the publication of the SOS and Adams studies. All of these patients in the Liang et al. Study from Formosa presumably had a BMI less than 35, as their average preoperative BMI was 30. And none of the patients in the Mangroni et al. Study from Rome had a BMI less than 35. And each one of these RCTs, surprise, surprise, confirmed the case series and cohort studies, even in those previously resistant to medical management. It was like reinventing the wheel, and I don't think the wheel was ever subjected to an RCT. There were 110 patients, however, in these RCTs who did have a BMI less than 35, and all of the studies found significantly better outcomes in these type 2 diabetics in the surgical arm. Now there are a large number of new diabetic medications being heavily promoted on television for type 2 diabetes, resistance to standard therapy, with several more in process. There are GLP-1 mimetics, some SLG2 inhibitors, and a number of others are PP4 inhibitors. The ones most frequently advertised are Trulicity, a weekly injectable, and Jardiance, a daily pill. These are all very expensive. Most of them have a risk of inducing pancreatitis, renal dysfunction, as well as other complications. And the question will be as to one of these drugs will be less expensive than a mostly one-time operation over 5 to 10 years. Furthermore, none of these treat any of the other complications of severe obesity previously discussed. In 1993, Kuzmak's gastric band was modified so that it could be inserted laparoscopically. The lap band took over the bariatric world, especially in Europe. In the US, the lap band was subjected to a 3-year FDA clinical trial with an investigational device exemption, or IDE, before it would be given a pre-market approval, or PMA. We were one of the study sites, and although we had a couple of patients who did very well, we had many others who lost no weight or little weight despite frequent adjustments of their band, and overall weight loss was equivalent to the VBG. We also began to see some patients with a dilated esophagus and became quite concerned. Interim Corporation tried to get the approval from the FDA after 2 years of their agreed-upon 3-year trial. And that's when I showed up at the FDA, expressing my concerns about the efficacy and complications of the lap band, and recommended it not be approved until the previously agreed-upon 3-year data were evaluated. The FDA panel agreed that certainly did not endear me to the device company. However, the next year, 2001, the lap band was approved somehow, given a PMA, despite the absence of another formal safety panel. A few years later, I did a live simulcast with Jacques Himpens and Guy Cattier, watching them place a couple of lap bands in Brussels. And I warned them that they were going to be taking a lot of them out someday and converting their patients to gastric bypass. They chuckled, but I think I got the last laugh. One of the recent papers, they found nearly 60% of the patients require removal of their bands, and they no longer recommend it. Most surgeons have abandoned the band, primarily because of inadequate weight loss, but also because of problems with band erosion, esophageal dilatation, and port side problems, as well as the availability of the sleeve gastrectomy. We'll see how well Governor Chris Christie, a lap band patient, does as compared to Al Roker, who had a gastric bypass. It clearly is the safest but least effective of all the bariatric procedures, except perhaps for the V-block. This was one of the first studies on conversion from a band to another procedure, the gastric bypass, for failed weight loss or esophageal dilatation, and our fellow in the audience, Shano Katari, presented it and was vilified. He thanked me for giving him this opportunity, not. Despite the company's advertising reversibility as one of the benefits, taking a band out for whatever reason and converting to another bariatric procedure is much more complicated than a primary, more effective operation, or taking the band out and doing nothing else leaves the patients with 2 operations and no weight loss. I thought their advertising its reversibility was unethical. Toward the end of my career, the laparoscopic gastric bypass, as you know, was introduced by Alan Whitgrove. My colleagues, Eric DeMaria and Mike Schweitzer, both here, began to develop this approach. I watched from a distance. As their technique gradually improved, I felt it was time for me to learn. Now, but although this was a spectacular advance in bariatric surgery, the early days were a disaster around the country. Many patients were severely injured by incompetent surgeons who felt that they had to do the gastric bypass laparoscopically to remain competitive. Television and newspaper articles were calling the surgery extremely dangerous due to all the major complications and deaths. Thanks to Walter Porys and others for developing the initial program for hospital and surgical accreditation. We should have known that this was going to happen based on the epidemic of life-threatening common bile duct injuries in the early days of laparoscopic cholecystectomy. And I was remiss in letting these weekend courses take place at our institution and view this as another one of my major errors. Now we have accredited and minimally invasive fellowships throughout the country and have the combined accreditation program, the MBSA QIP. Although the gastric bypass is a great operation, there are several major downsides. The risks of a leak and an internal hernia, which, when properly recognized promptly, are easily fixed. If not, they lead to death. Other risks of those are those of intermittent severe hypoglycemia and Wernicke-Korsakoff encephalopathy. From 1982 to 2000, our group had performed several thousand open gastric bypass procedure. At the same time, I had been providing surgery for patients with inflammatory bowel disease, Crohn's disease, and ulcerative colitis. At this time, I noticed the development of paresthesias in my hands and my feet. An MRI showed multiple areas of cervical stenosis, and I was scheduled for surgery on December 6, 2002. In late November, National Geographic came to record a gastric bypass procedure on a patient to appear in their issue called FAT, and an ABC to do a story on an adolescent who was to have a gastric bypass on their program, 2020 program, their Friday evening news program. Fortunately, these procedures went well, and I wasn't featured as an impaired surgeon on Sunday evening's 60 Minutes. I had my surgery with laminectomies at C2, 3, 4, 5, and it took me almost a year to recover. As a surgeon, I can attest that it's much better to give than receive. And that was the end of my surgical career. And I was ready. About the time I retired, the ASBS, now the ASMBS, decided to establish its own bariatric surgical journal, and I was given the opportunity of becoming the editor-in-chief of SWORD. I was able to remain clinically active in my devoted field after retiring. To my pleasant surprise, the journal did much better than I could have ever predicted. Our first impact factor came in at 2.9 at 3 years and progressively rose from 4.1 in 2012 to 4.9 in 2013. Unfortunately, because of our increased number of publications, the journal's impact factor fell back to 3.9 this year, but we are still ranked 16th of all 135 surgical journals. The number of articles we are receiving has progressively increased to more than 600 per year, with many coming from overseas, as the impact factor made SWORD an attractive journal for them. We are now completing our 14th year of publication, and I am grateful to the ASMBS for having given me this opportunity and sticking with me. I welcome Raul Rosenthal as co-editor this year. During these years, while I was editor-in-chief of SWORD, I continued to work on my hypothesis that developed from my research on the chronic abdominal compartment syndrome associated with obesity. It seemed as if all of the complications from increased intra-abdominal pressure were the same as the symptoms present in women with preeclampsia, the second biggest killer of pregnant women. Despite an ID from the FDA and multiple IRBs, we were unable to study this hypothesis in Norfolk, Virginia, Jackson, Mississippi, Padua, Italy, or Cuenca, Ecuador. So after all these failed attempts, I lost a lot of money, threw in the towel, and became rather despondent. I'm still convinced that an increased intra-abdominal pressure is the cause of preeclampsia. My life as a bariatric surgeon was exciting. I worked hard, enjoyed every minute. There were a lot of ups and downs, but the ups far outweighed the downs. After I retired, Betsy and I moved to Sanibel, Florida to begin a new life. It was a great place with new friends and interests. Everything seemed perfect until one day on May 31st, 2 years ago, I decided to hang a bird feeder from our kitchen window and fell. My life changed in a split second, not only for me, but for Betsy and the children. So begins the last and most challenging part of my journey. I was airlifted to the ICU in Fort Myers, where I spent 10 days, then Learjet to Shepherd Rehabilitation Center in Atlanta for 3 months. While there, I developed severe urinary tract infections, the first one with septic shock, and another stay in the ICU for 10 days. After a couple more UTIs and a couple of attacks of C. diff colitis, I was reminded that the solution to pollution is dilution, and drank more. I was able finally to begin rehabilitation. I had a C6 injury and a burst fracture at T5. Slowly, I learned to move my arms and hands, although my hands are still quite weak. I could not move my legs. I was able to resume work on SWORD, which was a lifesaver, and I'm very grateful to Bruce Wolfe for helping me out those 2 months of my true disability. This is one of my grandchildren while I was at Shepherd, and my lovely wife. After Shepherd, we moved to Utah, where one of our children lives. We started therapy at the University of Utah and then found a place called NeuroWorks and had a wonderful physical therapist. Betsy drove me 35 miles each way up and down the mountain 3 days a week. We found a psychologist who was very helpful to both of us. We stayed in Utah almost a year and then moved back to Sanibel this past October. I was nervous about coming back for rehab because we were leaving state-of-the-art facilities. Amazingly enough, Betsy found a physical therapist who we'll see soon, Ray, who I've been working with for almost a year. He is the first person after 2 years who started to work with my legs. And most importantly, they're beginning to move, and he gave me hope. I have learned that life is precious and never be taken granted. Be aware of how fragile our lives are. During these 2 years, I've experienced so many different emotions: anger, guilt, depression, and hopelessness, and more. I've learned that suffering is everywhere. Like Betsy says, if you think you have problems, just look around. I've learned that it's not how many papers you write or how many kudos you get or what titles you have, but what makes your life worthwhile are the people who love you and who you love. I've learned the true meaning of friendship and what those friends mean to me. Someone sent me a card every week. I also received hundreds of cards from others, and surprised, not one of them were alike. Walter Porys sent me a watercolor kit, and this is an example after a long time of my first watercolor. Bob Brolin has called me every week, and Phil Shower checks in periodically. Move it forward, please. I've learned that no matter what life throws your way, you have a choice. You can either accept it or do nothing, or you can change your situation and work for a change. I've decided to do the second, and believe me, it has been much harder than working every other night in a trauma surgery and all the other times spent doing surgery and taking care of my patients. I learned what it's like to be a patient, the fear and uncertainty of not being sure what's going to happen and what will be the result. Be thankful for the little baby steps of progress. Set goals, but realize that things don't always go that way we want. But that doesn't mean to forget these goals. They just might take a little longer to achieve. As a surgeon, I always wanted to see a quick result, but I have learned that sometimes we have to wait, and what we wish for may take a little longer than we want. Finally, I've come to understand what tough love really means. Catherine, our daughter, says Mom's like a dog with a bone. She's been on me from the beginning and doesn't seem to let up. She has made me angry and very frustrated at times, mainly because I am not used to having someone else, especially my wife, tell me what to do. But I now realize that without her, I would either be dead or lying in some nursing home. She has taught me what the true meaning of love is, and for that, I'm really grateful. She has taught me that she will never give up on me, so how could I ever give up on myself? To summarize some of the lessons I learned through my career, and we're missing one slide, don't let mental illness get you down. Be supportive of others when they are down or have a substance abuse problem. Don't believe everything a professor tells you. Beware of authoritative articles, even those in very prestigious journals. Don't take rejection for a concept or manuscript you believe in without fighting back. Be open to new ideas and concepts. Don't jump into a new idea or procedure without an adequate education or training. Conduct clinical research and publish your results, like here, both good and bad, so that it can be a benefit to patients around the world. And finally, don't fall out of a window or off a ladder. My sincere thanks are owed to my colleagues, you in the audience and the ASMBS, but especially our leader, George Ann Mallory, and the Executive Council for supporting me as Editor-in-Chief of SWORD for the past 14 years. And last but not least, my wonderful, beautiful, supportive wife, Betsy. It was primarily her work that we have 4 very productive, successful adult children and 9 terrific grandchildren. Thank you for listening, and thank you for your friendship over the years. Life is a journey, and now, as a late friend of ours said, every day I see the sunrise, that's a good day. Thank you.
What a legend. What a treasure. Thank you, Dr. Sugerman. Masterful lecture. As president of the ASMBS, I have the pleasure of offering you this plaque as acknowledgement. It says, "Be it known, the Society hereby recognizes and honors Harvey Sugerman, MD, as the Edward Mason Founders Lecturer."
Thank you very much.
You're welcome.
Thank you, everybody. Bye-bye.
Bye-bye. Thank you again. All right. Well, that was fantastic.